Brow rejuvenation is one of the most common but easily misunderstood procedures in plastic surgery.
Oh, absolutely.
Yeah.
It's really all about hitting that aesthetic sweet spot, without giving the patient that dreaded, perpetually surprised look.
Right. So welcome to this deep dive where we are moving past those outdated aggressive techniques.
Yeah, we're going to dissect the precise surgical anatomy, those specific retaining ligaments, and the endoscopic techniques you actually need to achieve truly natural functional results for your patients.
Exactly. Because before we even touch a scalpel or, pick up an endoscope, we need a complete mechanical understanding of the tissue layers.
You're managing a dynamic tug of war beneath the forehead skin. I mean, you cannot effectively suspend tissue if you don't understand the underlying forces fighting against your sutures.
So true. We are talking about the elevators versus the depressors. And when it comes to lifting the brow, you basically have exactly one workhorse.
Right, the paired frontalis muscles.
Yeah. But the frontalis is anatomically pretty strange compared to other facial muscles. I mean, it doesn't originate from bone and it doesn't insert into bone.
And that structural quirk dictates its entire function. The frontalis is essentially composed of two distinct functional halves. You have the superior half, which is basically static.
Because it's tightly adherent to the galea ponderotica.
Right, exactly. That galea serves as its functional origin point. But then you have the mobile inferior half, which hangs freely. That part inserts directly into the orbital portion of the orbicularis oculi, the overlying skin, and the depressor muscles.
And that mobile inferior component is what provides the entire range of motion for brow elevation.
Yeah. When the frontalis contracts, those superiorly directed forces pull that mobile lower soft tissue upward, crushing it into the fixed superior forehead skin.
And that repetitive mechanical folding along the deep dermal insertions is exactly what physically breaks down the dermal matrix over time.
Which creates those deep transverse forehead lines. Meaning, if you want to treat those lines, you have to address that specific muscular tension.
Right. And then you have the antagonists, the depressors. They work synergistically to pull the medial and lateral brow down.
Yeah, they form a really distinct grouping. You've got the corrugator, supercilii, pulling the brow down and medially.
Which causes those vertical globular angry lines.
Exactly. Then the orbicularis oculi is responsible for the crow's feet. The procerus pulls the medial brow straight down, creating those transverse lines at the root of the nose. And finally, you have the depressor supercilii.
Common pitfall right here. The depressor supercilii is a very superficial little muscle.
Oh, yeah. It originates on the frontal process of the maxilla and inserts obliquely onto the medial fibers of the frontalis.
And because of its superficial position, residents often inadvertently transect it during their dissection.
It happens all the time.
If you cut the depressor supercilia, you completely lose that downward medial pull. The medial brow just shoots up unopposed by the frontalis,
leaving the patient with a permanent shocked expression. And that is incredibly difficult to correct.
We obviously want to avoid causing iatrogenic deformities.
Right. But if you're aggressively dissecting in that plane to manage the depressors, you are venturing into highly unforgiving anatomical territory.
Knowing where the muscles live is just basic anatomy.
Yeah, knowing how to preserve the innervation and the vasculature while achieving your release, that is what separates an average outcome from an excellent one.
Let's talk about those danger zones, starting with the motor innervation. How do we avoid paralyzing the exact elevator we are relying on to hold the brow up?
We're looking at cranial nerve 7, specifically the frontal branch.
Right, which supplies the frontalis, the superior orbicularis oculi, the superior procerus, and the transverse head of the corrugator.
You need a mental map of that nerve trajectory before you even make your incision. The frontal branches course from a point about 5 millimeters below the tragus to a point 15 millimeters above the lateral brow.
So when you are performing your dissection over the zygomatic arch, those branches reliably sit about 2.5 centimeters lateral to the lateral canthus.
Exactly. That puts them roughly halfway between the lateral canthus and the inferior helix.
Okay, so that covers the motor side. But sensory preservation is honestly just as critical for patient satisfaction.
Oh, totally. That brings us to the ophthalmic division of cranial nerve 5. Specifically, the supraorbital and supratrochlear nerves.
The supraorbital nerves exit the supraorbital foramen, about 2.4 to 2.5 centimeters from the midline?
Yeah, right in that pocket. But the structure that gets injured most frequently is the deep division of the supraorbital nerve.
which runs superiorly between the glia and the periosteum to supply the frontoparietal region.
Right. It pierces the glia 2 to 2.5 centimeters above the orbital rim and just continues superiorly, staying within a centimeter or two of the temporal fusion plane.
I want to clarify the mechanism of injury there, actually. Surgeons often think they are safe if they aren't cutting blindly.
Right, but sharp transection isn't really the primary issue here.
No, it's traction injuries. Scraping blindly against the periosteum with a rigid dissector can stretch that deep division like a rubber band.
And that aggressive traction is the primary cause of post-op temporoparietal paresthesia. You really have to use your endoscope and be hyper-aware of the tension you are placing on the tissues in that specific vertical corridor.
Absolutely. And moving laterally from the nerve, the vascular anatomy presents an immediate threat to your surgical field.
The arterial supply to the forehead is robust and redundant, sure. But there is one specific venous structure that dictates the pace of your lateral dissection.
The sentinel vein, also known as the medial zygomatico-temporal vein.
Yes. And it is remarkably consistent. It travels perpendicularly straight through the temporoparietal fascia.
Reliably sitting 2 centimeters lateral to and just above the lateral canthus.
Staring the sentinel vein is a classic endoscopic nightmare. One careless sweep of the dissector, the vein avulses, and it will instantly fill the optical cavity with dark venous blood.
It completely ruins your endoscopic visualization.
You go from a controlled, elegant operation to just struggling to find the source of bleeding through a tiny port, risking severe post-op ecchymosis.
Yeah.
You must identify it early and dissect cleanly around it.
So assuming we have navigated those nerves and vessels without incident, we have a fully mobilized forehead. What exactly are we trying to build with this loose tissue?
Well, the aesthetic ideal for the brow has shifted significantly. Relying on older textbooks will definitely lead to unhappy patients.
Yeah, the old standard was the Westmore criteria from the 1970s.
Under that framework, the ideal brow peaked directly above the lateral limbus, and the medial and lateral endpoints were supposed to sit perfectly leveled along the exact same horizontal axis.
Which mechanically and aesthetically just failed patients. It often resulted in this harsh, artificial look.
Today, patients want a brow that peaks much further laterally. The modern aesthetic target places the peak at the junction of the middle and lateral thirds of the brow.
And even more importantly, the lateral third must be elevated relative to the medial and middle portions.
We could actually quantify this for the operating room. The ideal female brow should begin medially, right at the caudal aspect of the superior orbital rim.
With the superior portion sitting 1 centimeter superior to the orbital rim and 5 to 6 centimeters inferior to the hairline.
Right. And it also needs to clear the upper eyelid crease by roughly 1.6 to 2.5 centimeters.
I do need to interject with a strict warning here regarding gender differences. Those metrics apply strictly to the female brow.
Oh, absolutely. The male aesthetic is entirely different, and the margin for error is essentially zero.
The ideal male brow should sit right at the level of the superior orbital rim, and it has a significantly flatter arch.
If you apply the female metrics to a male patient, over-elevating the brow or creating a pronounced lateral peak, you immediately and permanently feminize the upper third of their face.
The surgical plan must be strictly tailored to the patient's underlying skeletal structure and gender. But let me challenge a common patient perception that really complicates these consults.
Go for it.
In real life, patients frequently sit in the exam chair, pull at their upper eyelid skin, or point to their brow bone, insisting they just need a blepharoplasty or that their bone structure is sagging.
Right. But the bony anatomy of the forehead rarely changes as we age.
Exactly. The superior orbital rim might look more severe due to adjacent volume loss, or it might be masked by descending fat, but the bone itself is rigid and static. The core physiological issue driving the aging appearance is soft tissue laxity and brow ptosis.
That descent is entirely a soft tissue phenomenon. Therefore, your surgical rejuvenation has to focus on releasing, redraping, and resuspending those specific tissues.
You cannot just drag the skin tight with a suture.
No. To achieve that laterally peaked aesthetic without fighting the native tissue architecture, you have to selectively dismantle the retaining ligaments.
Which are the true mechanical anchors of the forehead. Recent cadaveric studies have completely remapped our understanding of how the brow is tethered to the skull.
These are not flimsy adhesions. They are dense, fibrous thickenings that securely bolt the soft tissue to the bone.
You are dealing with three distinct anatomical anchors in the central and medial forehead.
Right. You have a supramedial attachment located roughly 11 millimeters above the supraorbital rim.
Moving laterally, you find a superlateral attachment about 10 millimeters above the rim.
And finally, there is an inframedial attachment positioned right at the level of the orbital rim.
These structures originate from the bone, pierce straight through the periosteum, and insert directly into the frontalis muscle and the deep dermis.
But the critical surgical finding is the broad ligamentous structure extending across the lateral aspect of the supraorbital rim.
Reaching out to the superior aspect of the lateral orbital rim.
Yeah. That broad lateral ligament inserts directly into the superficial temporal fascia. Surgically, this structure dictates whether your operation succeeds or fails.
Here's the key point. You must release that broad lateral ligament completely.
Completely. If you leave even a few fibrous bands intact, you cannot optimally elevate the lateral brow.
The remaining ligament will just act like a tension cable, constantly fighting your suspension sutures.
Until those sutures eventually cheese wire through the soft tissue over the next 6 months and the brow drops right back down.
So the lateral side demands complete release, but the medial side requires the exact opposite approach.
Yes. Preserving the medial retaining structures is the primary mechanism for controlling the medial brow.
You dissect a central narrow tunnel between the two supramedial attachments.
This gives you just enough exposure to resect the corrugator and procerus muscles, but you deliberately leave the medial ligaments intact.
Because those preserved medial attachments act as a pivot point. They tether the medial brow in place, preventing it from spreading laterally or sliding too far up the forehead.
Preserving them mechanically prevents that unnatural, perpetually surprise complication we talked about earlier.
Translating this anatomical roadmap to the actual patient requires meticulous planning. The operation really starts in the pre-op bay with a mirror and a camera.
You must examine the patient sitting upright in front of a large mirror, capturing dynamic photographs. You need images of them in repose, smiling naturally, squeezing their eyes tightly closed, and in full frontalis contraction.
Because patients are notoriously blind to their own baseline facial asymmetries.
Oh, incredibly blind.
A patient might have a left brow resting 3 millimeters higher than the right for their entire adult life, and they have never noticed it.
But the morning after surgery, they will scrutinize every square millimeter of their face in the mirror.
If you haven't documented that asymmetry and shown it to them preoperatively, they will firmly believe your surgical technique caused it. You have to manage those expectations before they even reach the OR table.
Definitely. Now, transitioning to the operative technique, the field has aggressively moved away from the traditional coronal incision, and the reasons are entirely based on patient morbidity.
The coronal approach requires a massive ear-to-ear incision across the entire temporoparietal scalp.
You elevate a giant flap. It carries a notoriously high risk of alopecia, especially if the scalp is closed under any tension.
And it leaves a massive telltale scar. It also guarantees a higher incidence of permanent scalp paresthesia because you are transecting countless sensory nerve branches.
The endoscopic approach mitigates almost all of those risks. You place small, vertically oriented incisions a centimeter or two behind the hairline.
You develop a blind subperiosteal dissection plane posteriorly to release the scalp from the skull.
And then you drop in the endoscope for the precise superperiosteal dissection down in the lower forehead.
You visually identify and preserve the deep division of the supraorbital nerve. You navigate around the sentinel vein.
You aggressively divide the lateral retinacular ligaments while leaving the medial anchors intact.
And once the tissue is completely mobile and tension-free, you face the mechanical challenge of locking it into its new elevated position.
Which is where the unicortical tunnel technique comes in. It provides a highly reliable, rigid, bony anchor.
You are typically creating 4 distinct tunnels, 2 on each side of the skull.
You use a specialized drill bit fitted with an 8mm stop. That stop is non-negotiable. It ensures you drill into the outer cortex of the skull without plunging dangerously into the inner table or the dura.
And the geometry of the tunnel matters immensely. You create the anterior tunnel by driving the drill into the bone at a precise 45-degree angle, sweeping the bit from the 5 o'clock to the 7 o'clock position to widen the track.
Then you initiate your posterior tunnel roughly 2.5 millimeters behind the first hole.
You drill 3 individual adjacent holes in a row, gently moving the bit superiorly and inferiorly to connect them beneath the surface.
Which creates a completed, continuous posterior tunnel. That bony cleat is incredibly strong.
You pass a curved needle directly into the anterior tunnel and guide it out through the posterior tunnel.
We typically use permanent 3/0 nylon for the suspensory sutures. You take 3 robust bites through the deep dermis, the ponderotic tissues, and the glia to ensure the soft tissue won't tear through.
Let me drop a rapid-fire surgeon tip right here. When you are tying down that deep dermal suspension suture, the mechanics of your knot tying dictate the longevity of the lift.
Yes, absolutely.
You must use a firm vertical rocking motion to seat the knot deeply. You have to ensure there is absolutely zero slack on the first throw.
It must be locked down tight against the bone before you lay down the subsequent throws.
If you leave even a millimeter of slack in that first throw, you immediately lose your meticulously planned elevation and the brow will sit lower than you intended.
Executing the suspension flawlessly is satisfying, but the procedure does not conclude when the scalp staples are placed.
Right. The immediate post-operative management, particularly the first few hours, heavily influences the final aesthetic outcome.
That critical post-op phase begins while the patient is still on the operating table, specifically during the emergence from general anesthesia.
The extubation process must be perfectly smooth. You need seamless, proactive communication with your anesthesiologist.
You cannot allow the patient to wake up coughing, bucking on the endotracheal tube, retching, or experiencing severe rebound hypertension.
Any sudden spike in venous pressure or violent head movement drastically increases the risk of blowing a freshly coagulated vessel beneath the flap and forming an expanding hematoma.
And hematomas in this space are disastrous. They stretch the tissue, compromise the suspension sutures, and can lead to flap necrosis or infection.
If there is brisk bleeding, it requires prompt operative evacuation.
To mitigate this risk on the floor, the patient needs to sleep with their head strictly elevated on a wedge, with their neck slightly extended to promote venous drainage.
And all NSAIDs must be held to preserve platelet function.
Beyond managing bleeding risks, you have to actively manage patient anxiety regarding nerve function. Waking up with paralysis of the frontalis muscle is a well-known, highly distressing complication.
It is terrifying for a patient. I mean, they look in the mirror, try to raise their eyebrows, and nothing moves. You have to confidently reassure them.
In the vast majority of cases, assuming you visualized and protected the nerve, this is a temporary neuropraxia.
It is caused by the inevitable traction placed on the temporal branch of the facial nerve by the retractors during the endoscopic dissection.
And this neuropraxia almost always resolves spontaneously within 3 to 6 weeks.
However, permanent injury to that motor nerve, while rare, is a devastating reality.
It must be thoroughly and clearly discussed during the preoperative consent process so the patient is not blindsided.
Altered scalp sensation, numbness, or tingling posterior to the incisions is also incredibly common, but generally resolves over several months as the cutaneous nerves regenerate.
Mastering this procedure really comes down to a profound respect for the anatomy.
We've broken down the dynamic tension between the elevators and depressors. We mapped the specific danger zones, highlighting the sentinel vein and the deep division of the supraorbital nerve.
We defined how the modern aesthetic target has shifted laterally, requiring precise, selective release of the broad lateral ligaments while preserving the medial anchors.
And we secured the result with the rigid mechanics of the unicortical tunnel. It really is an operation where millimeters of precision yield massive differences in the patient's perceived age and expression.
Very well said.
Before you scrub into your next case, consider this final variable. We established that the bony anatomy of the orbital rim remains relatively static as a patient ages, and that brow tausitis is fundamentally a soft tissue phenomenon. But how might volume restoration, specifically using targeted autologous fat grafting, change our surgical algorithm?
That's a great question.
For a patient whose severe soft tissue deflation is essentially masking their true ligamentous anatomy, restoring that lost volume might alter the vector of your lift, or even dictate whether an endoscopic release is fully necessary at all. Something to think about. Keep refining your anatomical knowledge, trust your technique, and control your variables in the OR.